History of cerebral aneurysm, diagnosis and monitoring of vasospasm. History of aneurysm identification. The aneurysm originated from the Greek aneurysma, where ana meant across and euris meant broad. The Alexandrian surgeon Rufus of Ephesus in 177 BC studied aneurysms. Galen was probably the first one to define and describe the entity aneurysm. And Tylos in the 2nd century AD distinguished between true and false aneurysms. Arabian surgeon al-Zawari Abulcasis, 913 to 1013 AD, performed surgical treatment of aneurysms. Abu al-Qasim Khalaf, 1013 to 936, popularly known as al-Zahrawi, Latinized as Abulcasis, from Arabic Abu al-Qasim, was an antidelusional physician, surgeon, and chemist, considered the greatest surgeon of the Middle Ages. He's been described as the father of surgery. He was born in the city of Azahara, 8 kilometers northwest of Cordoba, Andalusia. His birth date is not known for sure, however, scholars agree that it was after 936. The year his birthplace city of Azahara was founded. Al-Zahrawi also pioneered neurosurgery and neurological diagnosis. He is known to have performed surgical treatments of head injuries, skull fractures, spinal injuries, hydrocephalus, subdural effusions, and headache. The first clinical description of an operative procedure for hydrocephalus was given by Al-Zahrawi, who clearly describes the evacuation of superficial intracranial fluid in hydrocephalic children. Galen of Pergamon, born 130 AD, Pergamon, Turkey, died 210 AD, Rome, Italy. Full name, Claudius Galenus. Nationality, Greek, often angelicized as Galen, better known as Galen of Pergamon. Galen's major contributions to medicine was his work on the circulatory system. He was the first to recognize that there are distinct differences between venous, dark, and arterial, bright blood. Although his anatomical experiments on animal models led him to a more complete understanding of the circulatory system, nervous system, respiratory system, and other structures, his work contained scientific errors. Giovanni Battista Morgagni, 1682 to 1771. Giovanni Morgagni of Padua reported an autopsy case and suggested that aneurysms could be the cause of intracranial hemorrhage. Tradition says the Anatomy Theater of Padua University is the oldest in the world. It was built and paid for by Gerolomus Fabricii, who, at the time, was professor of anatomy and surgery. The structure was designed by Fra Paolo Sarpi. Dissection was carried out in secret as it contravened both the civil and religious laws of the period. History of aneurysms clinical diagnosis. The first reports of possible connection between intracranial aneurysms and SAH were by Bonnet, 1679, and Wiseman, 1696. John Blackwall of Oxford, 1813, was the first to describe a ruptured intracranial aneurysm confirmed at autopsy. Dr. Agos Moniz, 1874 to 1955. In 1926, Agos Moniz carried out the first cerebral angiogram in dogs and in 1927 in human. In 1933, Moniz reported visualization of cerebral aneurysm. In 1949, he received the Nobel Prize for his discovery of the therapeutic value of leucotomy in certain. History of M. Hewer and W. Dandy. In 1916, Hewer and Dandy at the Johns Hopkins reported the case of 26-year-old telegraph operator with a history of sudden violent frontal headache, nausea, and vomiting for years before admission, in whom complete blindness in the left eye subsequently developed, followed by partial visual disturbance in the right eye. The X-ray demonstrated a series of shadows consisting of broad curved lines and plaques. The patient refused an extensive operation. 18 months later, he experienced an explosive headache, vomiting, and loss of consciousness and died. At autopsy, 2 giant aneurysms were found. History of aneurysms, surgical and endovascular management. Ligation of carotids. In 1911, H. Crushing described his vascular clips. Walter Dandy of Baltimore, MD, the first to successfully clip an intracranial aneurysm on March 23, 1937. Fyodor Serbanenko introduced balloon occlusion in 1971. Guglielmi G. et al. Electrothrombosis of saccular aneurysms via endovascular approach in 1991. Types of cerebral aneurysms. Cerebral aneurysms are classified both by size and shape. Small aneurysms have a diameter of less than 15 millimeters. Large aneurysms include those classified as large, 15 to 25 millimeters, giant, 25 to 50 millimeters, and supergiant, over 50 millimeters. Saccular aneurysm refers to any aneurysm with saccular outpouching, including Berry aneurysms. Saccular aneurysms are the most common form of cerebral aneurysm. Berry aneurysm is a type of saccular aneurysm with a neck or stem resembling a berry. A fusiform aneurysm describes an aneurysm without a stem. Most common location of aneurysms: ACOM-A, anterior communicating artery, 30–35%. Bifurcation of ICA, internal carotid artery, and PCOM-A, posterior communicating artery, 30–35%. Bifurcation of MCA, 20%. BA bifurcation, 5%. Remaining posterior circulation arteries, 5%. Aneurysms risk factors. More common among tobacco users: alcohol or binge drinking. Hypertension may be a risk factor. Increased rates in women using oral contraceptives. Drug use, particularly stimulants or cocaine. Gender: in most series of aneurysmal SAH, there is a striking female preponderance. Genetics: family history up to 11%. Geographic factors: the incidence of SAH higher in Finland, Japan, and low in New Zealand and Middle East. It varies significantly from 20 to 23 per 100,000 in Finland and Japan to 812 to 100,000 in other regions. SAH, subarachnoid hemorrhage. SAH etiology: aneurysm 51%, hypertension 15%, AVM 6%, other 28%. Aneurysmal SAH presentation: sudden severe headache. The hallmark of aneurysmal SAH headache is that it develops within seconds. It is critical to inquire on how quickly the headache developed. Even a careful history cannot distinguish between headache secondary to aneurysm rupture and other more common and benign forms of headache. SAH outcome: 30-day mortality rate still high. Many patients die before or shortly after reaching medical attention. Large percentage of survivors suffers from cognitive sequelae even after successful treatment. Pathophysiological alterations following aneurysmal SAH: intracerebral and interventricular hemorrhage, hydrocephalus, cerebral edema, seizures and seizure-like activity, alteration in respiratory function, effect on the heart, fluid and electrolyte disturbance, cerebral ischemia. Cerebral vasospasm clinical significance. The Fisher scale. The Fisher scale is a way of grouping subarachnoid hemorrhage CT scans into 4 groups according to the amount of blood and is useful in predicting cerebral vasospasms. Group 1, no blood detected. Group 2, diffuse thin, less than 1 mm SAH with no clots. Group 3, localized clots and/or layers of blood greater than 1 mm in thickness. Group 4, intercerebral or interventricular blood, plus or minus SAH. Glasgow Coma Scale, GCS 15, no deficit. GCS 13 through 14, no deficit. GCS 7 through 12 may be a neurological deficit. GCS less than 7 may be a neurological deficit. SAH diagnosis, MRI and CT. SAH diagnosis, MRI. In the acute phase, MRI with flare demonstrates SAH as reliably as CT. MRI is superior to CT in evaluating extravasated blood after a few days, up to 6 weeks, and is a useful tool in patients referred in a delayed fashion if the original diagnosis is in question. Non-contrast CT scan confirms subarachnoid blood in 98% of patients if performed within the first 12 hours after onset. Distribution of blood on CT provides information on the origin of the SAH. Diagnosis and monitoring of vasospasm. Angiography. Degree of angiographic vasospasm does not always correlate with the clinical condition. Some patients remain asymptomatic with severe vasospasm demonstrated by angiography. Incidence of angiographic vasospasm is nearly twice that of DID, delay ischemic deficit. Cerebral vasospasm and delayed ischemic deficit, Dorsch et al., 1994. Literature review of more than 30,000 cases. Angiographic vasospasm occurred in 43.3%, range 19% to 97%. DID occurred in 32.3%, range 5 to 90%. Outcome of DID, death in 30.3%, permanent deficit in 34%, good outcome in 35.7%. Role of TCD, SAH. In symptomatic patients, elevated CBFVs most likely represent significant vessel narrowing and may obviate the need for cerebral angiography. Asymptomatic patients without elevated CBFVs probably can avoid additional angiography. However, we need to consider patients' age because elderly patients could develop vasospasm in normal or slightly abnormal CBFV range. Factors influencing interpretation: patient age, the presence of moderate to severe anemia, HCT less than 27, impaired CBF autoregulation, passive CBFV variation with MAP changes. Role of TCD, vasospasm monitoring. It is useful to perform TCD test on admission or ASAP after surgery and perform daily TCD studies when patient is in the ICU. The frequency with which the TCD should be performed may be guided by the patient clinical presentation, knowledge of risk factors for vasospasm, early clinical course. TCD studies should be performed after endovascular treatment to identify patients with recurrent vasospasm. The presence and temporal profile of CBFVs/PIs in all available vessels must be detected and serially monitored. The pattern of CBFV's elevation may indicate the need to follow patient carefully for evidence of defects related to specific vascular territory. Waveform, CBFV and PI change appearance either regionally or globally may be clinically significant. TCD can be useful pre, intra, and post-operatively. The value of the TCD in clinical practice is well established, while helping to recognize the development of, especially to measure and grade vasospasm following cerebral vasospasm before the onset of its clinical. Vasospasm following SAH is a very important source of morbidity and mortality. Too often, the first sign is a neurological defect, which may be too late to reverse. Based on AHA guidelines and many years of clinical practice, TCD is a tool employed by the neurosurgeon, neurointensivist, and neurologist in the management of vasospasm. TCD could provide information about abnormally high ICP, subarachnoid hemorrhage and vasospasm, anterior circulation vasospasm criteria: 100 to 139 mild, 140 to 200 moderate, over 200 severe. Posterior circulation, 60 to 68 mild, 81 to 100 moderate, over 100 severe. Tumor resection and vasoplasm, probable mechanism. It is suggested that accumulation of blood in the basal cisterns may have been responsible for this unusual condition, and it is therefore important to consider vasospasm as a probable etiological cause for clinical deterioration in patients undergoing the surgical removal of a cerebral tumor. For this reason, whenever any neurological deterioration occurs in such patients, it is advisable to perform TCD in order to verify the presence of any vasospasm and promptly commence suitable treatment. It is useful to perform TCD test after surgery and perform daily TCD studies when patient is in the ICU. The frequency with which TCD should be performed may be guided by patient clinical presentation, knowledge of risk factors for VSP, early clinical course. TCD studies should be performed after endovascular treatment to identify patients with recurrent VSP. Get in touch with us. Feel free to email or text and schedule a Class 101 or regular online session anytime. The TCD Project at gmail.com. Visit our website to stay updated, www.thetcdprojects.com. Book your appointment with us at 786-683-0083. 25101 The Old Road, Santa Clarita, California, 91381.